Hello, and welcome to this webinar for the Pain, Mind and Movement SIG. My name's Tory Madden. I'm a postdoctoral research fellow at the University of Cape Town in South Africa. The topic for this webinar is learning of fear, learning of pain. I'll be discussing some of the things I learnt and thought about alongside my colleagues and mentors during my PhD candidature. Just to give you a bit of an introduction to me, I come from Cape Town, South Africa. And I travelled to Adelaide in Australia to work with Lorimer Mosley and the Body and Mind team there, and then to Leuven, Belgium, to work with Johan Flyen and his research group in health psychology at the University of Leuven. And then I went back to Australia and back to South Africa, and I'm now based in Cape Town, as I said. What I speak about today has been contributed to by many people, some of whom I've named here alongside the funders of my work. So any of the ideas that I put forward today will almost certainly have been strongly influenced by some of these people. Right, so the plan for today is to talk about how we learn to fear. And I want to be very clear that when I speak about learning, I'm really talking about classical conditioning. So it's a particular form of learning, originally, I suppose, put forward by Pavlov in his experiments with his dogs. So when I speak about how we learn to fear, I'm really speaking about how we learn via a classical conditioning process to acquire fear, and then how we apply that learning to new situations. We'll talk about differences in learning between people with chronic pain and those who don't have chronic pain, and we'll talk about what fear learning hints at about pain itself. And then we'll look directly at this sometimes controversial question, could pain also be learnt via classical conditioning process? So let's start off talking a little bit about fear. If I showed you this Alsatian, and if you like dogs, you might think, oh, sweet, cuddly Alsatian. Let's have a little pat, a cuddle. Maybe I can have a friendly encounter with this Alsatian. So let's say you approach it for a pat, but the Alsatian turns nasty and bites you. Next time I show you that Alsatian, you might not think it was quite so sweet and cuddly. In fact, I would expect you to have a fear response to that Alsatian because you've learnt to associate the Alsatian with being bitten, which is an inherently unpleasant experience. So when I show you the Alsatian, I would expect you to have fear. On the other hand, if I showed you this Labrador, if you're able to distinguish between the Labrador and the Alsatian and identify that they're effectively different dogs, I might expect you to consider the possibility that the Labrador might not bite you. And if you then approach the Labrador for a pat, because let's be honest, this Labrador is pretty cute. If you approach this Labrador for a pat and a cuddle and it didn't bite you, I would expect that next time I showed you this Labrador, you wouldn't experience fear to the Labrador. So because we researchers like to put things onto graphs, if we were to graph your fear to the Alsatian compared to the Labrador, we might expect it to look something like this. A lot of fear to the Alsatian because you associate the Alsatian with being bitten, and not very much or perhaps no fear to the Labrador because you associate the Labrador with not having been bitten. This is called a classically conditioned response, and it's been investigated in many different fields, many different domains. But for the purposes of today, because this is a webinar for the Pain, Mind and Movement group, I'd like to introduce you to some lovely research done by Anne Mulders, who's based at the University of Leuven. She used a movement-based paradigm in order to investigate classically conditioned fear of pain. Anne asked her participants in an experiment to move this joystick either to the left or to the right during a learning phase. Each time they moved the joystick to the left, it was paired with a painful zap. So they got an electric shock whenever they moved the joystick to the left. Whenever they moved the joystick to the right, there was no painful shock. So they did this a few times. Left, shock, right, no shock. Left, shock. And in fact, the movement to the left, because it's positively associated with the shock, was called the CS+, the conditioning stimulus plus, positively associated with a shock, and the movement to the right, negatively associated with a shock, is called the CS minus. That's just a bit of classical conditioning terminology that I'll use as we go through this presentation. So that was Anne's learning phase, and then in her test phase, she asked participants to perform the same task, either moving the joystick to the left, the CS plus, or to the right, the CS minus. But this time, neither was paired with a shock, but she assessed fear. So how much did the participants fear moving to the left compared to moving to the right? Now, she was looking for something similar to what I explained to you with the Alsatian and the Labrador. More fear to the movement that was associated with the painful shock, similar to more fear to the Alsatian that was paired with a bite than to the Labrador not paired with a bite. So she was expecting more pain to the CS plus than to the CS minus. And this is approximately what her results showed. So over 4 test blocks, she showed that participants consistently showed more fear to the CS plus than they did to the CS minus. The full paper is published in the journal, not in the Journal of Pain, in Pain, and was released in 2011. So if you'd like to look at that in more detail, please go and have a read of the paper. So effectively, Anne demonstrated a classically conditioned response of fear of movement-related pain, perhaps. And so in a movement-based paradigm, she replicated this idea that fear can be a classically conditioned response. The next question is, well, can we then use what we learn about fear or learn about threat in new situations? In other words, if I have taken you through this procedure of being bitten by the Alsatian and not bitten by the Labrador, and then I show you novel dogs, dogs to which you haven't yet been exposed, and I choose those dogs quite carefully so that they lie along a continuum of similarity between the Alsatian and the Labrador. So here I've chosen a lassie dog, or a collie, because I think it's quite similar in colouring to the Alsatian. And then I've chosen a golden retriever because it seems to lie between the Alsatian and the Labrador, but is perhaps more similar to the Labrador than the collie is. If I showed you those novel dogs, would you be able to extrapolate your prior learning about the threat value of the Alsatian compared to the threat value of the Labrador to these new dogs? So you have previously experienced the Alsatian paired with the horrible experience of being bitten, and you've experienced the Labrador without being bitten. Would you then extrapolate your knowledge of fear or your knowledge about threat to demonstrate fear to these new dogs? If you did, we would call this a generalized response. And the terminology here is that you have generalized your response to the Alsatian and your response to the Labrador to novel stimuli. And we expect the graph of your responses to the different dogs to show a gradient according to the continuum of similarity along which the dogs lie. So in this next study, published in Pain again, this time in 2013, Anne used exactly the same learning phase and principle. Movements to the left, the CS plus, were paired with a painful shock. Movements to the right were paired with no painful shock. And before I go any further, I must put in a caveat here. I'm explaining Anne's studies in quite a simplistic way for the purposes of this webinar, but there are many more details to the study which made it tight from an experimental point of view, so I would encourage you to read the full paper if you want all the details of that. So for this study, the learning phase was the same as the learning phase used in Anne's 2011 study. This time, during the test phase, participants were not required to perform the CS plus and CS minus. Instead, they were asked to perform diagonal movements with the joystick. And these diagonal movements, shown in the paler colors, are similar to the CS plus or to the CS minus. So we would call the diagonal movements that lie around this original CS plus GS pluses, generalization stimuli plus, and the diagonal movements that lie around the CS minus, GS minuses. So to remind you, Anne's participants were first required to move to the left and got a painful shock. Move to the right, no painful shock. That was in the learning phase. In the test phase, they were required to perform diagonal movements that were similar either to the CS plus or to the CS minus. And again, she measured fear. To what extent did participants fear performing the diagonal movements that were similar to the CS plus? And to what extent did they fear performing the diagonal movements that were similar to the CS minus? If we look at her results, we can see that, in fact, the fear to the GS pluses and the fear to the GS minuses lie pretty neatly along this expected continuum, or this expected gradient of fear to the CS plus compared to fear to the CS minus, with the GS's lying between them along a continuum of similarity. So if we superimpose her previous results with the CS plus and the CS minus, although they were obtained in a different study but with the same design, same basic learning phase design, we can see that in fact this fear gradient does show up in her work. So we're seeing a generalized response gradient effectively across the two different studies. And in fact, this resembles the generalized response gradient we would expect if we showed you stimuli that lay along a continuum of similarity, just as I illustrated with the dogs. This generalized response gradient of fear is widely considered to be normal, to be adaptive, because of course it's helpful if we can learn about threat in one situation, and then when we're presented with a different similar situation, we can extrapolate the learning from the first situation to the new situation, rather than being required to learn something all over again. This is a helpful response, and it's a kind of learning that we use in everyday life as we grow up and as we experience life. So a generalized response gradient is in fact considered normal. Interestingly, some people with pathological fear show what's called overgeneralization, and their response gradient is a lot flatter. So I've illustrated that using the dogs here. If you imagine that someone didn't learn that the Labrador was safe and they still showed fear to the Labrador, we would expect their generalized response gradient to look a bit more like this, a bit flatter, and we would call this overgeneralization. Now, interesting, in Anne's other studies and in some other studies that I haven't specifically cited here, it's been found that people with chronic pain show signs of more contextual fear, slower learning about cues for safety. In other words, they might be slower to learn that the Labrador is safe. Increased protective responding to safety cues. Again, although the Labrador is a safety cue, they might show this heightened fear to the Labrador. Excessive generalization about danger, and slower learning that previously dangerous cues are now safe. In other words, they seem to be less efficient at updating their learning to account for safety information. So that's interesting because so far we've only spoken about fear, but now there seem to be some links between fear and how specifically we learn about fear and chronic pain. And if we think about the idea that pain can be considered to be a perceptual response to perceived or actual threat to bodily tissue, to my mind, that begs the question, could these differences in learning also underlie persistent pain? And that brings us to this idea of generalized pain. And here I've cited the imprecision hypothesis of chronic pain, which is a published paper by Mosley and Flyen, published in Pain in 2015. That paper put forward the idea that pain could become a generalized response. And it used the idea of a patient similar to this patient Sharon, who I'm about to introduce to you. So this is Sharon, and Sharon first injured her back. She did sustain tissue damage when she was picking up something heavy. But now it's 6 months later, her tissue has healed completely, but Sharon still has pain whenever she bends forward to pick something up. Interestingly, she also has pain whenever she bends to pick up something very light. She also has pain putting on her shoes. And she has pain when she does activities like playing the piano, or chopping vegetables, or cooking. Now, when we think about a story like Sharon's from a mechanical point of view and from a mechanistic point of view, it would be difficult to explain Sharon's experience purely on the basis of central sensitization at the dorsal horn. It would also be difficult to explain it using the idea of ectopic firing of damaged nerves, because Sharon doesn't have any clear neuropathology. It's also difficult to explain with psychopathology because she's psychologically stable. So, could this be called generalization of learnt pain of some sort? In other words, if we think about this generalized response gradient that we would expect to dogs, this generalized response gradient of fear, and the idea that overgeneralization might be a feature of people who have chronic pain, is it possible that what we're really seeing in Sharon is something similar, an overgeneralization, though not specifically of fear, but of pain? So let's think back to the joystick paradigm. Fear can be a classically conditioned response. And we also know from some of her work that fear can be a generalized response. In fact, that's been demonstrated by many other people besides her, but she's specifically demonstrated it in the context of movement, which is interesting and useful for us. So fear can be a classically conditioned response and a generalized response. Our question then is, can we say the same for pain? So what are we really proposing here? Well, the way I think about it is, if you imagine Sharon in the acute tissue damage stage, each time she bends forward to pick something up in this stage, she has a lot of nociception, presumably from that damaged tissue in her back. And she experiences pain each time she bends forward with that barrage of nociceptive input. So there's this repeated pairing of bending forward, nociception, pain, bending forward, nociception with pain, bending forward, nociception with pain. When she's performing activities like standing, we would expect her to have far less nociceptive input and no pain. Once her tissue heals, if pain can be a classically conditioned response, and if it's an adaptive response and happens in every normal situation, we might expect Sharon still to have pain each time she bends forward, because the bending movement was previously associated with nociception that was sufficient to elicit pain. So bending, nociception, pain, bending, nociception, pain during the acute stage, a little bit like Alsatian bite, fear, Alsatian bite, fear. So once her tissue is healed, we might expect Sharon still to have pain each time she bends forward because of the association between bending forward and nociception sufficient to elicit pain. Whereas we might expect her not to have pain in the standing position because the standing position was not associated with nociception sufficient to elicit pain, a bit like the Labrador paired with no bite. So we would expect her to show this differential pain response depending on whether she's bending forwards or standing up. And I hope that to you that's starting to look a little bit like the Alsatian and the Labrador with fear. So this question, can pain be a classically conditioned response, has evoked a lot of debates, and I think there's good reason for that. We did a survey to look at what clinicians think about this idea. Do clinicians endorse the idea that pain can be a classically conditioned response to non-nociceptive stimuli? And we found that yes, in fact, most clinicians seem to think that pain can be a classically conditioned response to non-nociceptive stimuli. And interestingly, most of them also think there's evidence to support that idea. We then did a systematic review that demonstrated, well, in fact, there's not enough evidence to say whether or not pain can be a classically conditioned response to non-noxious stimuli. We followed that up with a first experimental study which had null results. In this study, we tried to test the idea that a classical conditioning procedure can lead to a shift in pain threshold, and we didn't find any shift in pain threshold in our healthy participants. We followed that up with a second experimental study, which I would argue had a stronger design, but of course I'm a little bit biased about that. In this study, we delivered stimuli to participants' backs. We used vibratory stimuli at two different locations, shown here in pink and green, as CS plus and CS minus. We paired vibration at the CS plus with very painful stimulation in what's marked here as the main laser stimulation zone, and vibration at the CS minus with non-painful laser stimulation in the same zone. That was our learning phase. In a test phase, we then paired an at-pain threshold stimulus, laser stimulus, with vibration at the CS plus, and the same intensity of, in other words, at-pain threshold laser stimulation with vibration at the CS minus. And we asked participants to report on whether that stimulation trial was painful or non-painful. Now, in theory, an at-pain threshold stimulus should be painful 50% of the time and non-painful 50% of the time, because it lies exactly at the boundary between painful and non-painful. Our results showed that stimuli that were paired with the CS plus, at-pain threshold stimuli paired with the CS plus, were painful more than 50% of the time, whereas at-pain threshold stimuli paired with the CS minus were painful less than 50% of the time. So in that study, we demonstrated biased perception of at-pain threshold stimuli after a classical conditioning procedure. The next requirement really in this line of inquiry is an experimental study to demonstrate pain to a non-painful stimulus due to a classical conditioning procedure. In other words, to test this idea that a stimulus that is non-painful at baseline might be rendered painful due to classical conditioning. That study, to my knowledge, has not yet been done. So at this stage, we know that we learn to fear by association. In other words, classically conditioned fear. We know that we're able to generalize what we learn about threats to novel situations. We know that some people report pain to a widening array of triggers, and that looks like what could be called overgeneralized pain. And we know that people who do have chronic pain show overgeneralization of fear. We don't know whether pain can be learnt by association. In other words, whether pain can be elicited by association. So we don't know whether we can generalize what we learn about threat to elicit pain to non-dangerous triggers. We also don't know whether classical conditioning can explain a story like Sharon's, where she has pain to a widening array of triggers that differ increasingly from the originally dangerous movement. So that leaves us in this interesting situation where we know that fear can be learnt. That's been demonstrated. What has not been demonstrated is the idea that pain can be learnt by classical conditioning. And yet, treatments for learnt pain have been developed, and their efficacy has, to some extent, been demonstrated. So we're left with this gap in the pipeline, as it were. And I would argue that this is reasonably important as a consideration, because many of us in the clinical context use the idea of classical conditioning or the classical conditioning framework to reason clinically about our patients and to choose treatments for them. So I suppose the elephant in the room effectively is, well, what do we do now? How do we change the way we think about patients? Should we change the way we think about patients while we wait for the research world to catch up with clinical thought? Or is that completely the wrong way to think about it? So here's some food for thought. Have you ever used terms in your head or in your speech that imply that certain things need to be uncoupled from one another in order for your patient to recover. Perhaps that movement needs to be uncoupled from pain. Or the idea that things have become linked, cues or stimuli or movements have become linked to pain. Have you agreed with this idea that has been put forward in the literature that pain memories are capable of evoking pain in isolation? Or have you thought of the idea of neurotags as an associatively learnt phenomenon? If you'd answer yes to any of those questions, I would suggest that you might be using a classical conditioning framework to understand persistent pain. And I'm not very clear on whether or not that's a problem, because I use this system for thinking myself and I find it useful. And I think it's very important for us to distinguish between the idea that classically conditioned pain has not been demonstrated and classical conditioning pain has been demonstrated not to exist. It hasn't been demonstrated not to exist. The current state of the evidence is we don't know. So here are some ideas for what we might discuss in the forum after this webinar. I'd be interested in your thoughts on alternative mechanistic explanations for what I'm calling a generalized pain picture. I'd be interested in any other explanations you have for this kind of story, Sharon's story. Or do you have any alternative mechanistic explanations for the efficacy of some treatments that I think many of us have used a classical conditioning framework to explain? And the ones that come to mind most readily for me are the graded motor imagery program, various exposure treatments, and perhaps there are others that you think of as well. And then I think it's important for us to have a discussion about whether or not we should change our clinical reasoning at this stage. That's the end of this webinar. Thank you very much for joining me, and I look forward to hearing or reading what you have to say on the discussion.